Welcome to PodTox. We are on episode 14, and right down here, I got it kind of right, we have Jenny, who was nice enough to be our surprise guest this week, and then, of course, Marie, the lovely co-host. So with Jenny, we're going to get into a whole bunch of stuff. We're going to talk about just MAP medications and jails, detox centers, everything involving recovery, just so we can get a different perspective from a nurse's side of thing too. So we want to start off with kind of what got you into the space. Why did you start just getting into addiction? Because I feel like it's not something that somebody just falls into.
No, and actually, so I'm a late bloomer nurse. So I just graduated maybe 10 years ago. And I was doing inpatient at large hospitals, and it wasn't for me, especially cardiac unit. I was like, I'm not cut out for this. So I went to my local organization here, and I started off, I was a nurse case manager for refugees. So we would take in refugees, and we were their first medical stop, and we would follow them over the years, to make sure that they got their green cards and became citizens and all that jazz. But then there was a travel ban. So then my organization's like, hey, what kind of nursing don't you want to do? And I'm like, kids, don't put me with kids. I don't want it. And so they said, all right, how about psych nursing? And that was the second one. I was like, oh, God, no. But I said, yeah, let's do it. Ended up loving it, like falling in love with psych nursing, became board certified in psych nursing. But with that comes the dual diagnosis, right? You have psych nursing, but then you also have addictions. So roughly 3.5 years ago, maybe the organization's like, hey, we're going to start up a MAP program. We want you to be the charge nurse. And I was like, what on earth is MAP? So they told me the medications that we were going to start using, which at the time was just strictly Vivitrol. So I got Vivitrol and I took home a patient insert and I read it back to front and was just trying to learn it over and over and over. And then just became so experienced in that. And then they added Suboxone. And I'm like, what on earth is Suboxone? So I had to learn about that. And then that just spiraled into such a passion, because once we started Vivitrol, like people were coming in and it's been growing and growing and growing. And then we introduced Suboxone, and then last year's Sublocade, like it's huge. And now we're going to be doing Brixadi. So
we've kind of asked everybody in the medical field how their education was whenever it came to addiction in general, because everyone said the same thing. They really didn't learn much about it, but I'm always curious.
Nursing school didn't have nothing on addiction, absolutely nothing. We didn't even talk about it. And we only had one class of psych. The rest was just physical illnesses and things like that. Nothing like that. So shooketh when I came to love psych and then addiction right next to it, because dual diagnoses, there it is. And it's just a hardcore passion.
What would you do on a average day? What would your day look like helping a patient if they just came in and maybe they're having issues with H or something? What would you do to start that process?
Since we've grown, we have such a huge team. So we actually have somebody that does the intake that will immediately put them in with one of our MAT doctors who leaves space Monday through Friday for new admits, possible new admits or new patients. And then from there, sometimes I sit in with her on the eval so we can just troubleshoot and figure out how to do it. Sometimes these people don't want help. I think they just want to know that there's a place for when they're ready, which is perfect, because then we give them all the stuff that we can, and encourage harm reduction. So if they're ready, we let them know what medications we have, and it's really up to them. We want them to choose which is going to be best for them, because let's say someone chooses Suboxone, that's probably because methadone didn't work for them in the past. They weren't aware of Sublocade. Vivitrol didn't work for them. So it's really patient-centered care. And then we just get it started. Some days I'm doing same-day injections, like same-day treatment. And then we're setting them up with IOP, therapy, anything that they need in the community. It's literally a one-stop shop where we're at.
I've had a lot of people that I've helped out too that have, whenever they went into the doctor, obviously their doctor was not super upfront with them, I guess. And this is kind of a hot topic whenever it comes to especially subs. So somebody goes in and they decide they're going to get on subs, and the doctor tells them what some side effects are, and they say like weight gain, you may get groggy, all the random stuff, but they don't mention anything about the teeth, which that's only somewhat of a big deal, but they also don't mention anything about like the mental side effects where it can give you more anxiety, it can take away your emotions, it can do all that. Do you think, first off, do you guys go into depth with that at all? Because I feel like it gets hard, because whenever you say something like that to someone who is struggling, they might take it and be good with it, or they might run away and it could hurt them.
So we do touch upon, let's talk about the teeth. We do talk about it, but we cannot directly say that that is something that Suboxone causes, right? So we just give out dental care tips. That's it. As far as mental health, absolutely. And I am huge on this because a lot of them are dual diagnoses. But when you have a substance and you're so dependent and you're addicted to this substance and you take that away, you're on that substance to cover something up, to treat something that you're experiencing. When you take that away, it's not the absence of the substance that's causing, depression, anxiety, any kind of mood disorders. Really, to be honest with you, it's something that you've had. It's something that you've had, and that medication that substance was masking anything that you may feel. And so we like to say this medication is not going to cause anxiety. It's not going to cause depression. It's not going to cause this or that. It's really a diagnosis that you've had before.
Do you go into like schools and talk to people or anything like that, or?
Man, do I wish I could do that. Ooh, because the damage of dare. I'm sorry, but no. So I have a correctional facility that I go to, and that's for the inmates that have chosen Vivitrol. So we are on a grant from our state where I'm the only one, the grant applies to me. I'm the only one that can go into that correctional facility to educate, to administer, all that jazz. The grant only applies to Vivitrol. Now we're working on having Suboxone and possibly Sublocade brought in. Inmates actually leave on the daily to go to a local methadone clinic too. It's been an issue because one time I went there to give Vivitrol to an inmate and he tested positive for methadone. And I'm like, hey, what's up? Like, what's going on with this? And he's like, well, someone's bringing back methadone from the clinic and just passing it out to all of us. So his pod was tossed, it was so bad. There was a huge investigation. Getting off course, but yes. So I do go into the correctional facility. We are opening something called CRC, Crisis Recovery Center, where it's going to be 24/7, where instead of bringing patients that are in a mental health crisis or anything substance use related to the ER, they're going to come to us. And so we're building that, should open within the next year, but we do not do on-site inpatient detox because we're not medical, we're more psych in our crisis unit.
How often do you have like people that are using other substances? Because a lot ends up in some jails, at least. Some jails are pretty clean, but for the most part, like Matt Keegan talked about, subs were running rampant through the jail. What are there like precautions or anything, or what do you have to do if that starts happening continuously?
So I don't know because I don't work at the correctional facility. That's not my home. But I've heard that our county is very strict. We have an awesome sheriff who runs this joint, like amazing, very open to substance use disorder and MAT and treatment. And so he's more compassionate than he is a punisher, if you will. Of course, if rules are broken, yes, punishments apply, but it's more met with empathetic care, if anything, and trying to figure out why this is going on, and then kind of altering the inmate's treatment to align with what's going on in their life. So I don't know how often it happens. Yeah, go ahead.
Do you think that it betters their life all around to be able to have treatment while they're in jail? Because I know that when I was locked up, I was fortunate enough to be able to get Suboxone because I was pregnant. But I felt like if they would have a program like that, which they do now, I feel like that's very beneficial for people because it gets them a jump start on being able to really get their feet planted in their recovery.
Absolutely. It's another tool in the toolbox, right? The recovery toolbox. But you're right. You're you're exactly right when you say it's a head start. So when I go and see them with the Vivitrol, it's either same day that they're getting released or it's a day before, right? So that's starting to work and they have that. It's not like it's at the end of the month where it's wearing off and there's a possible chance to return to use and overdose. Absolutely. Absolutely. Because when you're in jail and you have substance use and disorder, but you also have drug charges, they're going to do everything they can to make sure when you reintegrate that you're doing it in a healthy manner, right? Such a bonus for all inmates with substance use disorder to have MAT.
With Vivitrol, do you think that it's greater risk?
I do. And that's one of the things that I educate inmates and patients about in general, because Vivitrol, right, starts popping off the mu receptor after like 3 weeks, and it's leaving those mu receptors open, right? So if you return to use, you're not going to feel it as much. You're not going to feel whatever opioid you've chose to use. And so you're going to keep doing more and more and more until it literally starts kicking that Vivitrol off that mu receptor. And there's such a great chance for overdose.
How do you feel about Vivitrol in general? Just because obviously it's a good tool, but you have to be off of whatever substance you're on, at least a decent amount whenever you get on it. But also that's always been my like failing, I felt like, with Vivitrol, is you may use it for a few months and everything works out great. You know, you don't get the cravings as much, all that stuff. But you could just quit at any time, I guess, and then go back to using if that's all of a sudden what you felt like. What services are in place so that doesn't happen? Because almost no doctors that distribute Vivitrol end up actually doing like aftercare things, and I feel like that's what you need more than the Vivitrol, actually.
Mm-hmm. Our team is so awesome that when you use Vivitrol, you can stop it at any time, right? It's not even an opioid, right? It's just kind of hanging out, hoping you do the good thing. So you can stop it at any time and return to use. Absolutely, you can. As far as starting it, this is why it's so good for inmates, because they've already either detoxed or just been straight off the opioids. So we can come in there, give this injection, it's good. We find that it is very, very, very difficult, if not impossible, for people with opioid use disorder to stop for 7 to 10 days prior to starting Vivitrol. It is very, very tough. And so we don't have a lot of patients that are able to do that. But we have therapists that specialize in recovery. And so each MAT that we have, we didn't have this before, but now we do. Every single MAT that comes into our care, we automatically set them up with a therapist and a case manager.
I love that. That's my motto. I feel like therapy is a huge piece.
Absolutely. And so they'll do it for however long they see fit, whatever, and they'll take our recommendations. Now, if an MAT doesn't want to do therapy, okay, we can't make you, right? But we still know that the medication is important. It's a strong, strong tool in that recovery toolbox. So we'll go ahead and we'll let them go without the therapy. We'll try to set them up with outside services in our community that their insurance works with, if we can. It's really on the patient at that point. But they also know that we do not stigmatize. We do not judge. We do understand that somebody might not stay off H or F or anything. So the second that you return to use, hi, let me know, because you're alive. And that's what we care about. We can get you back in. And I don't care if you have to come back 10, 15, 20 times. We're going to be there. So we do have awesome, awesome services for our MATs.
I feel like that's a failing also of a lot of the MAT clinics now is, so like mine, whenever I went in, the doctor would usually take like an hour to get there, and beforehand we had group. The group was just us randomly like talking with a guy that had been with the doctor the longest, and he was actually studying to be a traveling nurse, so he knew his stuff, but there was no like accountability, no one-on-one help. You could ask the doctor, but it just wasn't enough. And fortunately with subs, I feel like you have a little bit more leeway where yes, you should go to therapy, but if you aren't instantly going to run back to the street. But yeah, I'm kind of disappointed in how it works with a lot of clinics. In my clinic, I felt like they probably did more than most do.
It's sad. It's sad because there's such a need. It's not just, oh, medication and you're good for some. It's medication, it's accountability, it's IOP, it's every kind of service, it's case management if you need help finding a job or transportation. And right now, actually, we're at the point where we're working with a large insurance company to provide MAT transportation because a lot of our MATs don't have a vehicle or modes of transportation, or they have to Uber. And let me tell you, like $56 just to go get a Sublocade or a Vivitrol to them is not worth it. And so then they stop coming back. So we're trying to work with this insurance company to get transportation on the house. Like help us out, help our patients out. So we're getting there. We're getting there.
How often is insurance a fight for everything? Because I know some insurances like Health Alliance is what I have now, and I don't think they cover really anything whenever it comes to like mat treatment in general. I could be wrong, but I got them right before I stopped, and it was useless.
So we only work with state medication. So Medicare, Medicaid, everything is covered. And I know like some people say, oh, that's impossible. It can't be. From where I stand, yes, everything is covered. But Vivitrol, we also get samples too. So even if you're, let's say, undocumented and you need this injection, but you don't have insurance, all right, cool. Let me just go get a sample and we'll start you on it. All of the things they're covered for our MATs. Every service.
I used to remember struggling to get to the clinic in the morning, and thankfully my state insurance covered for like rides. I would have to get like this paper filled out, and it was like this whole big process, but they provided transportation, and thank God they did.
And I know like some of the issues with transportation is if you have to set it up 3 days ahead of time, right? Sometimes it doesn't come to your house, doesn't pick you up, doesn't stop by wherever you are to come and get you. And so that's why we're working with this insurance company to try to get something more reliable so our MATs can recover without the stupid stress of transportation.
I wonder if you could run something like that through like Uber. Like have them be the ones. That would be a really big project, but that would be cool because it'd be reliable.
You can. We are working on that as well.
Gotcha. Okay.
We have one set up. We have one company set up. So, and it's so new. I want to say 3 weeks new, maybe.
Oh.
So we're still kind of working out the kinks, but we do have that.
That's awesome.
The red tape in that had to be ridiculous. I mean,
that's why I'm glad I'm just a nurse and I'm not the higher ups. I don't have to work with that kind of stuff. When we first started, I was writing standard operating procedures for the organization to approve. I was writing all these nurse things for the organization. And I'm like, oh my gosh, just let me treat people. And so I don't have to do that anymore. Out of my hands. Good. Bye.
Whenever it comes to Sublocade, because I'm guessing overall, if you could get subs being like one of the things that you can treat people with and then getting them onto Sublocade, how would that work grant-wise? Because I know there are grants and everything, but is the state really going to give out grants for subs? Vivitrol, I understand, because there's a lot less red tape with Vivitrol, but subs and Sublocade are probably extremely hard. So are there things that like once somebody gets out of jail, gets through the program, if they wanted to get on subs and Sublocade, could they get a grant because they got on while they were incarcerated? Or are there any options there?
They wouldn't need a grant really because that grant money doesn't have to pay for it because their insurance does. The only time they would need a grant really is if they were uninsured. But my inmates that come out of the correctional facility are already insured at that point. Before they're released, they're already insured, they're set up, everything's good, all their services are set up. So there's really no need for a grant for Sublocade, in my opinion, but maybe, but let's say there were. That might be really tough. That might be a tough one. I don't know.
I didn't know that you like set them up with insurance and everything after the fact too. That's crazy because that's what a lot of people struggle with. That's why they don't get the help they need because they don't have insurance that takes care of it. Like that's probably the number one thing that I talk to people about.
A lot of our inmates when they go in, actually, and this is probably just nationwide, but you lose your insurance, right? Doesn't matter if it's private or state insurance, you're going to lose it. And we have a team that sets them up with insurance prior to release. So then they just quickly transfer over to us and everything is smooth. We have their orders in for whatever medication they're on and they just come in and boom, done.
Wow.
Easy, easy, so easy. We actually, there's something, and I don't know if this is nationwide either, but there's something called the MAR line, the MAR Now line, Medication Assisted Recovery, that we have in our state here in Illinois. So if you're having a hard time finding a prescriber to help you with any MAT meds, you're set up, we give out the MAR line, MAR Now, and they can see a prescriber, I believe within 24 to 48 hours, who will prescribe the medication they're on for MAT, and then they transfer to us or whatever provider is close to them, local, whatever. So they're carried through until they get to see us or whomever. What? Amazing.
I'm in Illinois and I didn't even know about that.
You're in Illinois?
Yeah.
MAR Now.
Small world.
MAR Now.
So,
What's up?
so with you being a nurse, do you come across other nurses that might have had to take that job position because they needed the money and they're not really so empathetic towards people in recovery? Or, you know, you hear those stigmatizing things every now and then and you have to correct them? Or are people that usually work with you already in that headspace of...
It's so bad. It's so bad.
I'm sure.
It's so bad. So I'm the only MAT nurse right now. We have students from local colleges that will come in and they orientate for a day, whatever, just to fill their class time. I get to end the stigma or try to deconstruct stigma with them. Love it. Coworkers, on the other hand, man, these nurses, ooh, it is, it's tough.
Sure.
It is very tough because they're still using stigmatizing words all the time. And so I created this little education thing that I'm going to be doing in 2 weeks to all the nurses. Like, I feel like I have to do this all the time. How to use appropriate language when you're talking to somebody with substance use disorder. A lot of these nurses are old school. They don't have experience with substance use disorder, and they're just stuck in their ways, and it doesn't change. Gets me every time. Yeah, it's all over. It's all over.
See, and this is where I differ, and I've tried to talk to a lot of the harm reduction community about this and stuff like that. I understand the language and how the language can affect people. Obviously, it makes sense. I am of the mind, like, whenever it's me, I wouldn't care what someone called me. But that's just me. But because of that, I don't fully grasp all the harm reduction stuff. I try and practice it where I can, but I'm not even close to good at it. How much do you see it actually affecting people while they're in there?
It's really, honestly, it's not a lot. It affects me more. Wow, that's selfish. But it affects me because I have such a love for these MAT patients of mine or anybody with substance use disorder. And it has to do, like, if you go back, decades where people with substance use disorder or people, who use drugs, actively being hated on, not only by people on the streets or coworkers or peers, the government. And that's where the term, like, addict comes into play. It's from the outside, it's harmful because you see where it starts. You see where the stigma starts. And that's why I think language is so very important to try to deconstruct stigma and where it came from. Now, I've had a lot of people in the recovery community here, actually too, in MAT, that say, I don't care if people call me an addict. Like, this is my journey. I'm in recovery. I am not an addict, but I was an addict and I beat that. I came out of that. I'm doing great. I get it. Absolutely get it. I don't know.
That's kind of my thing. It's a weird situation, and I'm gonna get, like, killed for saying, or I shouldn't say that either, but I'm gonna get beat on for saying this. But I feel like, to a certain extent, whenever I'm trying to help people, if I use the harm reduction language, I don't actually help as many people, because people that are still in their addiction, they do not receive it the same way as someone in recovery would. So I have to actively avoid it sometimes, because if I say substance use disorder, I've had someone literally tell me, I saw you say substance use disorder in the first couple of videos I watched, and I just skipped on because I thought you were one of those harm reduction people. And it's like, like, how do you fix this stigma that is now against the harm reduction? Because everyone's teaching it when I guess not everyone should be.
And I guess I can't speak on that because I don't do harm reduction. I really just humanize, right? My whole thing is just humanizing anybody in the best way that I can, whether it's harm reduction or accepting somebody that's returned to use or is using. So I don't know. I can't speak on that. But I get it. I get what you're saying. And I struggle with that too. But because I'm on the outside, I will always say person who uses drugs, person with substance use disorder, because there's the person, person who, person with, and people who use drugs, people with SUD are people, right? I don't like saying addict because it's just got this demeanor to it. But again, I don't use. So that doesn't address me. I don't know. So maybe I should just mind my own sometimes, but I kind of feel like, oh gosh, if I can just humanize, let me do it how I can. But I don't know.
No, and you're right. I think there's a correct way to approach it, and that's where a lot of the disconnect is ending up. Just it's not everyone is going to be able to take something a certain way, and I know a lot of people that are in the harm reduction community haven't even experienced like anyone talking like that. That's because that person watching is literally skipping them, but just like some people probably skip me because I use the word addict or something like that. It's all about who follows you and who's interested, because a lot of people don't actually say anything.
When I
But
hear the word addict, my insides crawl. They crawl because I'm like, oh, it's a person. It's not an addict. But I get where people come from. That's their journey. If that's a title they so choose, fine. I support it. I love it. Whatever works. Whatever works. I can't do that. I can't do that.
I feel like I'm sure it's got to be so hard at your job to hear certain people. Like it must sting every time you hear people phrasing things certain ways.
Oh my
And
God.
I really commend you for putting together a little program to help educate. I would love to see what you say in that little program. Like, I would love for you to post that, to be honest with you.
I can understand because, and I know that we don't want to identify ourselves by drug use, right? Like, oh, heroin addict or whatever. But at the same time, a lot of people do identify themselves by that, not by the drug, but by that lifestyle. And so for me, when I have a nurse coming in working with me or that I'm training or a student, right from the get-go, you're going to sit down, you're going to chill out, you're going to learn. But I always tell them first things first, we are harm reduction focused here and language matters. And they will slip up and be like, oh, shoot, sorry. So now they're thinking about it because I don't think that people who don't have substance use disorder or don't use drugs ever get to use stigmatizing language. Ever. Because if you haven't gone down that path, if you haven't lived that life, it is not yours to speak of in that sense. It's tough. Oh, it's stupid tough, really.
what else do you end up doing? Because obviously language is a big part of it, and it's a big part of it on TikTok. But what other practices do you like have in the clinic that are like, okay, this is what I can do from a harm reduction standpoint?
Narcan. I mean, we have a Narcan vending machine, but also in my office, I'm in charge of our Narcan for the organization where I'm at, and it's just box after box after box after box. And every patient, here's some Narcan, here's some Narcan. Do you want some Narcan? But not only that, it's just loving, I guess, loving them, seeing them as people that have been hurting,
Right.
people that have been struggling. There's a reason for use. And we understand that even though we might not have experienced it, we're going to understand it and we're going to love you through it. We're going to love you along this journey. Anything harm reduction, we do tell them, hey, if you can stay away from injecting, please do so. My MAT doctor is an ER physician as well, and she'll check injection sites too. Hey, maybe we could treat you with this. Maybe you can go get treated for this. We give them out, local areas that they can go to get help. Anything that we can do. But I, in my teachings, will say illicit, because illicit fentanyl, because fentanyl is medication for pain patients. I never want to stigmatize that. So it's illicit or prescribed. When you come to me, I don't care why you're here. If it's illicit or prescribed, doesn't matter. So it's just making the difference between what is stigmatizing and what is not.
That's one I've definitely picked up is the illicit thing, because that is a super important distinction that I think scares a lot of people when they go to the doctor and it's like, oh, we're gonna put you to sleep now and all this stuff. It's like, I don't want you to give me that stuff, and they have no idea. Like,
And I've even recently seen a creator on here talking about how she didn't know that fentanyl was in the epidural. Sorry, I lost the word, epidural. And her and the baby tested positive after. But people fear that. I get that message a lot from pregnant ladies saying like, is my baby going to get taken like because I'm on MAT? And that's the saddest messages that I could receive.
And that's, I think, where stigma comes in. That's why we
You're
need to
right.
start deconstructing everything where it began and why every form of destigmatization is so dang important. Because it's not only affecting the person who used drugs, it affects everybody. I mean,
Yeah, and these women, like I just even received a message yesterday. This woman is terrified. She's 10 weeks pregnant. She's on Suboxone. She wants to wean off of it because she's terrified to go to a doctor. And I told her, listen, that's a chance of a miscarriage. Like, you cannot do that. Like, please, I tried to, but that's where the stigma is messing people up. And it's always seems to be with pregnant women with my messages.
yeah, because people seem so hell-bent on, oh, well, this mom's on MET. She doesn't deserve a child, a baby. You know, it's ridiculous. And that's why we need to end. We just have to do everything that we can.
I think part of the problem is too, so whenever I first started creating content, I'd been doing it for a few weeks and had gone through the WDs and all of that, and I was starting to give information about addiction and things that can help and all types of stuff like that. And I did a episode about pregnancies and what you can do. Before I did that, because I'm a guy and I don't know all of this stuff, I asked a few separate doctors, and they were addiction specialty doctors. Both of them told me that you want the patient to slowly get off of MAT and off of subs whenever you're about, before you give birth. Actually, it was before the third trimester. And these are addiction specialty doctors. So I took their word and put it out there and said, this is what I have learned. And then afterwards, I got grilled and was like, okay, let me figure this out. Because if I put out something, wrong, I want to fix it. And I talked to a few other doctors, and I found out that no, they literally just stigmatize the medication itself and think that because you're having a baby that you need to get off all of it, and they have decided that is the route everyone should take.
That is so dangerous. That is extremely dangerous. Extremely.
Yeah.
That is so disappointing.
Yeah.
How disheartening. Because am I going to come off my insulin? Because I'm having a baby?
Yeah.
No, I will die. Some people, when they come off their MAT meds, can possibly return to use if it is too soon. Bah, it drives me nuts.
And even with like a pregnant woman, my suggestion is stay on the medication. Don't, because they're like, oh, right when I have the baby, I'm getting off. Listen, you're a new mother. You're tired. You're going to be hungry, angry, lonely, and tired at times. You're going to need that medication on board because a lot of different life changes could literally put you right back into that situation again. And now you have a child. And now you're responsible for another life.
And I wish I could say something to agree or whatever, but then that would come off as medical advice, right? And I'm a nurse, can't give medical advice, but I like your point.
That is one of the hard things too, is because Dr. Ims touched on that a little bit. There's so much that she would like to say, but if it comes off as medical advice and someone takes that, so much can happen. And I think the problem with that is I don't think people actually understand what giving medical advice means. So they will go after someone because they gave medical advice when they really didn't, but the lawyer or whoever will still take it and run with it, and then that person loses their license.
Wow, this person in the comments said that they had to wean off of subs in the hospital in the first trimester.
Nuts.
That is. You know, it's crazy because I even just recently checked in with my Sublocade provider, and I was very taken back by information that they told me and information that I've learned here on TikTok, and it was about the fentanyl laced M. They told me that what I am perceiving is absolutely incorrect, that they see it on a daily basis in the ER. And I literally stopped in my tracks, and they said, listen, you're very educated when it comes to Sublocade and Suboxone, but you need to educate yourself when it comes to that. And I just stopped, and literally, I feel like I need to go in there and have a conversation now with like the charged person.
Did you tell them that the people just really don't want to say they're using fent, so they use that as an excuse?
Kyle, I stopped dead in my tracks. It was a new doctor, not the normal one that I seen, and a medical student, and they literally sat there, their heads spun around when I said what I said. And they said, listen, you got a lot of learning to do when it comes to that. Like, you don't know what you're talking about. And I literally just was like, I think you guys need to educate yourself.
And this is my point with this. When we go along, or when people are saying, oh, you know, this F lays to M, whatever you want to call it, we're not allowing a safe place for people to say, I used F. I use fentanyl. I use
They were telling me, they said we got 60, 70-year-old men coming into the ER testing positive. You have no idea. And listen, I tried to give my spiel and tried to educate them on the spot, but they were not going to be receptive to anything that I had to say. Trust me.
Well, and I wonder how many of those 60, 70-year-old men were once pain patients or something that could no longer get their pain medication, so they went to the streets, and that is why it's an actual problem. I mean, that's most likely that is it, but the doctors probably don't even know this, and this is something that I am trying to figure out how to help, and I think part of it, I'm not in the medical field, so I don't have those connects, but the education for doctors, even that are in the, mat world or anything like that, they don't know all the information. Like their job is to keep up with the information, and they don't. So there needs to be a way to hold people more accountable, I guess, because I think that's the problem. No one's holding anyone accountable, and they're just blaming all the pain pills on everything, and that's like the least of the problem.
And it's hard because, and I know you guys aren't in the medical field, but you have a doctor, you have a nurse. That nurse answers to the doctor, right? Imagine a nurse going up to a doctor being like, hey, I think you might be a little bit misinformed. They're going to be like, who are you? I have 20 years more experience than you.
Right.
And that's why I love my MET doc, because we can talk about it. She said something that was stigmatizing. I'm like, hey, let's talk about that. And she listened and she learned. And she also teaches me so much stuff. But there has to be a way. Absolutely. I think the doctors need to come down just a minute from that high horse, some of them, and just listen to communities that are trying to educate them.
I would love to go into my Sublocade facility. They do methadone, Suboxone, Vivid. They do it all. Basically a nice clinic wraparound. But I feel like they need education from our standpoint. They need to know the things like the doctors aren't getting in these books. Like, they need to learn different things. And I feel like they're a little out of date with certain things. But I'm glad that your doctor is not like that.
I'm so lucky to have such a great doctor.
You are.
And she sits down and she's like, all right, what questions do you have today? And she taught me about the half-life of fentanyl and how it's lipophilic, just all this stuff that I would never have had the opportunity before if we didn't bring her into our organization. And I'm lucky. Our patients are lucky.
Have you seen a lot of patients transfer from medicated assisted treatment off?
We have, and we have more that are on MET because we do encourage as long as you want. And we're still a new program, 3.5 years in. So we
Okay.
still have some from the beginning that are still on it, and we're okay with that. We have had a couple that have, we had one that was just on high doses of methadone for 20 some odd years. And she was like, I can't do it anymore. She got off methadone herself without any help from us within 2 weeks, came to us feeling horrible and was like, hey, sublocade me, do something, because I'm ready. Stable, doing great.
There's good success stories of people going from methadone to Sublocade. That is not talked about enough. That is absolutely something that I have so much passion for. And I feel like a lot of people need to know more about Sublocade and Brixadi.
We had one that got out of jail and she was on methadone in jail. So she would go daily to the methadone clinic and came to us and she's like, I want to be done. Like, I want to be done. Can I do Sublocade today? And we're like, hey, whoa, just a second. Why don't you at least try to see if you can tolerate the buprenorphine
Right.
and so we tapered her off and she tried a strip in our office of Suboxone. And she's like, yeah, I feel good. I feel really good. And then boom, we initiated Sublocade.
A
Amazing.
lot of people don't know about the directionality. That's what Dr. Nichols always talks about. Can you explain that to break it down to people that might not understand? Because a lot of people are fearful of precipitated withdrawal.
Yeah. And I had a couple videos up. Some of them were reported and taken down. And then I took down the ones that were left standing because people were like, you're giving medical advice. You can't do that. That's your license, blah, blah, blah. So I can't really speak too much on it. I can say what patients have done because that's
Okay.
not my experience and it's not medical advice. But a lot of our patients go down to about 30 of methadone. That's between them and their clinic. Sometimes my doc will take it on. Sometimes she just lets the clinic do it. And then when they're done, we see if we can tolerate it. And it's called macro dosing. And this, again, is not medical advice. But, man, you just throw them with Suboxone high doses of bupe, right? So it's going to clear that methadone off, the opioid, and quickly saturate and try its best to not give you precipitated withdrawals. It's a dangerous process. I shouldn't say dangerous. It's risky. It's pretty risky. But there's also microdosing too. Where you 0.5, and then 1 and 1 and then 2 and then 2 until you're where you need to be. It's possible.
I've had a lot of people too that have been scared of that exact process, but I've told them like the other option that you have is you try and go, without for a few days, work with your doctor, whatever, but you have to try and detox off it somewhat. And detoxing, I did it, detoxing off of methadone. I was on, like 130-ish, 135 milligrams a day and went cold turkey. You want to talk about hell. Like, fuck, it hurts.
I remember that in jail
So
with
bad.
over 400 milligrams of methadone a day. That was bad with benzos. It was no fun.
Oh,
Yeah.
you guys, I can't imagine.
I don't even know how we're still here, but I'm grateful that we're here able to share so that we can help inspire other people like Kyle. Detoxing down and titrating his dose down is something that I look up to that. Like that's amazing that you were able to do that. You know that?
I don't know. I just
Willpower.
had to get off the crap. Like I was all done with everything. I just couldn't do it anymore. And I know there's a lot of talk out there kind of about like abstinence being ineffective and all this stuff like that, which there's a whole bunch of different ways that can go. I don't want people to be afraid of abstinence, but if you're abstinent, you are responsible for yourself. You don't have a medication guiding you. You don't have all the time a doctor guiding you. It's all up to you. So I think that's where the failure kind of comes in whenever it comes to the abstinence. And if you're at least on a MAT medication, you can't just go out and use for the most part. And that's why so many people have good luck, but it comes with side effects. And that was my problem. I felt like I had literally no emotion. I had no sex drive. nothing. And it was like my I don't know, my drive to just do anything and be better and all that was completely gone. And I felt like that was all from the sub. So I was like, screw it, I got to get off.
Do you have more anxiety and underlying mental health issues?
So this is the thing I wanted to talk about too, because before I got on subs, even like with the pills, without the pills, it wouldn't matter because I had gone stretches without pain pills and been fine. My anxiety was never really an issue. I was a very social person. I could literally be in front of anybody doing anything. It wouldn't bother me. I got on subs. While on subs, I never felt anxiety. And then after I got off subs, anxiety through the roof. Like before every podcast, it's a little bit easier now. But before the podcast, I would literally be sitting here shaking trying to talk because my anxiety was so bad and I never had that beforehand. So I don't understand where that came from. And it could just be old age because I'm getting older.
I don't think it's because of old age, and I do need to mind what I say in this kind of discussion, but do you ever think that it's because, all right, well, you don't have that anymore? Like you don't have that medication anymore to kind of help you through at all?
So the longest I think I ever made it was 3 months, and that was after I got off methadone. And during that time, I never experienced any anxiety. Like, so I used to be a server too. I used to bartend, serve, all of it. And I was literally like the number one guy because I would take anything and everything, could handle anything and everything, and no issues whatsoever. And before I ever started the pills, same thing, no issues. The only time I would have issues is if I had to like in high school, if I had to stand in front of the class and be like give a presentation. I didn't like that, but that was it. And then this kind of just festered over the last, I don't know, probably like 5, 6 months.
How long were you using for?
uh Pills and methadone and all that, close to 10 years, and then subs for a little over 3.
And so how long have you been without any MAT meds?
I am a year and 2 months off, or a
I
year
can't.
and 1 month off.
Oh my God, that's amazing.
It
And so
is.
the anxiety just started within the past couple months.
It started like 4 or 5 months ago and slowly got worse. Like it didn't start out extreme, but I'd say the last like 3 months, it is just shot through the roof and
Have,
nothing's
have things
fixing it.
have things changed in your life?
Not really.
Have goals changed in your life?
I guess maybe a little bit, but still not crazy. One thing I did notice that started kind of getting to me once I got off the subs, I started losing my ability to just like be like if all the kids were asleep, the wife was gone, I had the place to myself. I could sit down on the couch and like play a game or something or watch TV, and I would never at any point feel relaxed. And that kind of continued for quite a while. I think that is slowly getting better, but I worried that maybe that was why the anxiety came on because I've gone so long where I just felt like I haven't relaxed at all.
Do you think it's trauma from like your active use and the things that you're like, oh my God, I did this to my kid and this and like the overcompensate and then all of it, it causes everything to fall onto your shoulders. So you're the one responsible to make everyone else happy. And that's a lot on someone.
True.
That's a lot.
That it is. And
It is.
I've came to peace with a lot of what I've gone through because I don't know, responsibility and stuff like that, that's usually not a that's not an issue that I like have because I handle my business. Whatever I got to do, I've always done what I got to do. But yeah, I don't know. I guess it's there a little bit.
I have no idea. I'm not a doctor, but
No,
ooh,
no,
man.
I think I'm just broken. It's okay.
No.
Listen, everyone, I'm a huge therapy person. I really think therapy would really be a useful tool for you. Seriously. I'm serious. Like to have someone neutral to just vent to every week, that vent ain't going through the walls to everyone else is what you need.
I just need time to go to therapy.
You
That's,
can listen, my therapist calls me on the phone.
yeah.
I
Yep.
don't even I don't gotta go nowhere.
That's what I would have to do.
Pop
Like,
it earbud in and keep it moving.
yeah. All right. Now that you guys found out how broken I am all the time, we wanted to talk about Sublocade and Brixadi too. Whenever it comes to like the differences, why someone would be administered Brixadi instead of Sublocade, since I know you can do Brixadi weekly and all that, but what do you feel like is like the actual difference whenever it comes to like the actives and what it actually does for your recovery?
So, because Brixadi is so new, I just took home the patient information 2 weeks ago. I was telling Marie about it. Maybe it was 2 weeks ago. Haven't gotten to that yet. Life is crazy. But from a nursing point of view, I like Brixadi better. And here's why. So, because it's buprenorphine, right? So it's a controlled substance. DEA is on our butts to make sure that we follow these rules, right? Well, Sublocade, we have to have like DEA approval on how we store it, like a double locked and all that jazz. It's
Right.
horrific.
It's red tape. It's a lot of red tape.
And so we had to get a special fridge. We had to buy special locks, and find whatever. Brixadi doesn't have to be refrigerated. Okay, might not be a big deal to you guys, but to us,
Right.
amen.
With Sublocade, you have to take the shot out, let it like sit for a little bit before you even inject it, correct?
15 minutes.
There.
Yep. And so with this, you can just grab it and go. Get it from the pharmacy and go. So we're trying not to store any kind of controlled substances in our medication room if we don't have to, right? It's a whole hoopla, whatever. But yeah, weekly injections. I don't know if I'm a fan of that. I wouldn't want to go somewhere to get a weekly injection. Give me the monthly and let it be done.
Right.
Because whatever. The gauge for Sublocade needle is not pretty at all. That is not pretty. And man, when you give it, it's not awesome what some of the patients can go through.
Also, I really think that it's not as bad as a lot of people make it out to be either. Like the things that I've done in my life, I'll take that burn for a few seconds. I'll gladly lay there and take that burn. Do what you got to do to not make me go backwards in life.
And here is what we have come up with when we started it, because we heard it was pretty painful, right? And I don't know how Brixadi is. I have no idea because we haven't administered it. But we give lidocaine. We do lidocaine injections, sub-Q, like right under the skin. And they don't feel a thing when we give that Sublocade. I don't know if we're going to be able to do that with Brixadi. I have no idea. But those two things I love about Brixadi. No refrigeration. Put me in coach because that's such a freaking hassle. And then, like, when you take it out, like, it's the viscosity, it's horrific, but it's wonderful. And you just have to let this little air bubble just float to the top, and you're just supposed to wait and watch, and it gets to the top. And then they tell you, well, it can be a range of colors. Like, it can be from white to clear to yellow to amber, and you're like, what the actual? Like, just give me one color. Amazing. It's amazing. But I don't think I could do a weekly injection. I don't know. As a patient, as a nurse, yeah, all the time.
Well, you know what? As a patient, I'm a patient that likes accountability. Accountability really, really, really worked for me. And I'm like a very ritualistic person. So maybe for people like that, they might actually like that because they know that they have to come in and give a urine every 5 days. That is the accountability portion that I think is going to help people.
That is such a good point, and I'm so grateful you said that because there are people that won't go on Sublocade because they like the daily subs, they just, or the pill or whatever, they like it. So thank you for that. I will actually take that in consideration.
Because a lot of people, they're fearful to do the whole month. They're scared of what the repercussions of a whole month worth of medication would do.
Well, and I've heard a lot of people mention that after, like, whenever they get their first and second Sublocade shot, that last few days, it's kind of not really working as much, and some people go through a little bit of something. So maybe for people that are afraid of that, the weekly could help kind of adjust.
It could. And so with Sublocade, and here's the thing with that. So you have the 300 milligrams and the 100 milligram injections, right? Most of the time, people will start off, and it's not medical advice, but most of the time, people will start off at 2 injections of the 300. So you'll give the 300, and then 26, 28 days later, you give another 300. By that point, they're really at a steady state of that buprenorphine. So yes, the first 2 injections can get a little hairy at the end, but I'm hoping to God that people that are going on Sublocade have a prescriber that understand
Right.
that they could need supplemental buprenorphine products just to get them through the end of the month.
We also have to be careful about that because I literally have a friend that she was given it. She was doing the whole Sublocade shot plus the 2 strips a day. She was not told by her doctor that she couldn't do that. And she got herself caught up being on 2 medications at the same time.
Yeah, absolutely. But not only that, constipation, guys. That's a thing.
Right.
That's a lot of bupe.
Yeah.
Got to think about that.
Yeah, that would hurt after a little while. I mean, what and I don't know if this is possible. I've heard a couple of people talk about it, but I can't find a lot of information on it. If you take the subs, and there's been someone that's commented on one of our videos about it, I think, but you take the subs and everything's good, you don't have an allergic reaction, you don't have anything. You get the Sublocade shot and something goes wrong. I guess it wouldn't be like an allergic reaction because you can't be allergic to it, but something could still go wrong. What do you do? Like, can you take it out? Because a lot of people worry, I'm going to have this thing in me for a month. And I've heard a lot of doctors say that is the case. Once it's in, you're kind of stuck.
So right when you inject it, right, and this is from my standpoint, right when you inject it, it's going to form that ball, okay? Yes. And you can even feel sometimes it's pushing the needle out little by little. But so that ball is formed and it's working. I mean, the half-life is what, 46 to 60 days, you know? And sometimes those patients come back and still 3 months later, you can feel a little lump. So it's going to be in there. It's going to be in there for a little bit. But if there is a life-altering or any kind of dangerous situation, you can actually go and have it surgically removed. You can. Never try to remove that yourself.
And also, I had a friend that I was guiding on here, and she ended up in the hospital with needing surgery, and she was on Sublocade. She messaged me immediately, terrified, like, oh my God, what am I going to do? I told her, you need to advocate for yourself. You need to explain to these doctors that pain is a trigger for you, and you really need to put your foot down. She was having issues with a couple doctors, but she got her point across. They ended up giving her Dilaudid, and it worked. It literally worked because they were able to give her high enough doses, and she was able to verbalize, like, listen, if you don't, I'm going to end up in a situation. And she got what she needed. And the next few messages were her so grateful that she used her voice.
I love it. Actually, Ashley's asking, can you verify how long it stays in your system? I'm 3 months out from the last shot. So the half-life, and let's talk about what half-life is. So 46 to 60 days, right? It's going to range because everyone's metabolizing medication different. But that takes 46 to 60 days for just half of that dose that they gave you to be eliminated or metabolized from your body, right? So it's not even the whole thing. So then you got to add on time after that. But we are experiencing, not us personally, but with other Sublocade clinics, 9 to 12 months, you're still going to test positive for bupe after your last injection. And we educate our patients on that because we don't want them to get in trouble with their POs or anybody, you know, jobs, anything like that, if they so test anything. So 9 to 12 is what we're hearing, 9 to 12 months.
And also, my doctor also told me, if you could still, because I could still feel little tiny, like I know where my injections were. They're super tiny though. But he said, even though you might be able to feel it, like say it was 40 days later, there's really no medication coming out of that. Like at that point, there's not that much medication coming out of it.
Minimal.
Yeah.
Minimal. Mm-hmm. Yeah.
So With the Brixadi, and you might not actually know this yet, is that going to be the same, and would it differ between the weekly dose and the monthly?
I don't know. I don't know. I can answer that when I read that patient insert, but I don't know.
I feel like that's something that could kind of change the game whenever it comes to people switching, because that's one thing that a lot of people get scared about. Like, what if I have a job that comes up within the next year that has to test for that and I'm just out of luck and I miss an opportunity? A year's a long time, and whenever you get off of everything, like you just transition from using to the shot, and then it's there for a year, a lot happens.
Well, and with you saying that, my mind's okay. So let's say they're doing a once a week injection. Does that mean that the half life is different, even though it's straight bube? So these are things to think about. If they're doing it once a week, is it not lasting as long? And I'm just thinking out loud. I don't know, but
Oh, yeah.
I'm gonna look into that. That's pretty cool.
So
Another
with
cool thing though, about injectable buprenorphine, will go Brixadi. So Sublocade is just in the abdomen. Brixadi has come out with this amazing, amazing, amazing thing. Anywhere sub-Q. It does not just have to be in your tummy, which I know it bothers guys a lot because that belt line, we need to avoid that belt line like the plague. We can't do it. So we're somewhat limited for guys who wear belts or like tie strings kind of thing. Um, for me, I wouldn't want one in the tummy. If that was the only area, great. But like, talk to me in the back of the arm. I want it in the back of the arm. It just feels more comfortable to some. And with Brixadi, they give that option. And I think it's so cool. And we have people who are coming out of active addiction weighing 100 pounds, 105 pounds. They're not going to have any tummy fat. We can't
Right.
give it. So you can do it in the flank area back here, where their love handles are kind of. And I love that. I love it. I love it. I love it.
going back a little bit here, what do you guys do for the things like constipation? Whenever you mentioned that, I thought of it. So if someone's having those issues, the constipation or weight gain or anything like that, what are kind of the options? Because especially the weight, a lot of people struggle with that, and no matter what they do, they can't seem to gain or lose
Right.
whatever.
So we haven't had anyone on Sublocade or any View product that's gained weight, oddly enough. And if they have, it's not obviously because of the Bupe, it's just because their lifestyle change. So educate them about the lifestyle changes that they're making. If they are gaining too much weight, that's not healthy for them. But that's up to them.
Which I've done whole videos on this, because you can do everything from changing your diet, you can start taking certain supplements, and then you can get kind of more extreme and take medications for it. But I've had a lot of people have success. They try and change their diet and it doesn't work. Once they start transitioning to supplements, that usually solves the problem. And the people that doesn't solve the problem, they honestly get so scared, because like they're just worried something's going to happen. Like, do you have a pile up in there, or what's going on? And that usually,
Probiotics is another thing, like
yeah,
Thank you.
natural.
Thank you.
yeah.
And that's a thing that not everybody experiences constipation, right? Let alone severe constipation, life-altering constipation, anything of the sort. But there's a chance. There's a chance. So it's something to educate yourself and talk to your care team about for sure. Absolutely.
How do you, with like your nursing career, like how did you present yourself when you first came online? Because I know that you can't give medical advice, but you're a huge part of the recovery community, trying to help advocate for us, and you're always trying to fight for what's right in the recovery community, and I admire that. Like, how did you present yourself though, without, there's a fine line there, because it's like you got to put out certain information, but certain information you can't speak on.
I don't even remember, to be honest with you. I cannot even remember. But so I've been on this social for 3.5 years, I think, and I was just shooting the stuff. Sorry, not doing anything of any importance on this app. And then being a nurse, I was like, well, I can use my voice. And this was before I got into MAT. I was thinking, God, I got to do something, nursing. And then out came TikTok. And then here we have COVID. And I was just speaking on ways to be safe. just ways to be safe in COVID, right? Oh my gosh, people tore my world apart. So I was like, all right, we're going to stop that. But then I got into MAT even harder than I was in the beginning. And I was like, I gotta let people know that these people are human. People who use drugs are human. Like that's what it is. That's bottom line for me.
You're very empathetic. You're a very empathetic person, and that makes for an excellent nurse. A nurse that has compassion and empathy is the full package. That's like the type of nurse I would want taking care of myself or my kids.
My doc sometimes says, Jenny, please don't cry. Are you going to see this
Same
patient and cry? Please stop crying, Jenny. Because I'm so empathetic and I can't imagine what you guys go through, but to keep coming back and fighting and fighting and fighting and fighting. What? Like, that is powerful. You guys are powerful people. What a community. Oh, you guys just get me in my heart.
Have you been able to help in any way whenever it comes to all the like DEA regulations and stuff like that, and all the, I guess, just crap they're throwing on top of pain patients and SUD patients and all that? Has there been anything that you guys have been able to do for the state or anything? Because I know a lot of people are trying, and it's a hard battle.
No, there's nothing because, number one, when it comes to the medical field, I am totem pole bottom, right? Bottom of the totem pole. I still have a voice for my patients and for the community, but as far as the DEA, no, we don't. We will take whatever the DEA throws at us, and we will make it work for our patients the best way to go around it that we can without violations, and just love our patients through it.
I'm always curious if anyone's found the loophole to try and help with it, but yeah, that's the thing. It's even Dr. Nichols was talking about, he tries to talk to like the state senator every once in a while or write emails or whatever he can do, and there's only so much. They don't want to listen to anybody unless they have money.
Yeah, I get emails on ways that we can institute change or initiate change if you donate $10,000. What? I don't have $10,000. So what? I gotta sit back and not change anything? Well, I'll change for my patients what I can, because I can't change much further than that, unfortunately.
Is there anything big that you are working on, which you talked a little bit about some of it, but is there anything big that you are working on just for the recovery community or MAT in general?
You know, and it's everyday life, not only in the office, not only in the jail, not only in the crisis unit, but stigma, man. That's where it's at for me. That's where it's at, because how can you have equal access to great care when there's so much stigma? That's my thing.
I would love to see that little thing that you're putting together for the nurses. I think that that's something that you should make public for the recovery community, because I think that would be helpful for a lot of people, including myself, to be honest.
Absolutely. Let me finish it up, and then absolutely.
I love that you're doing that, though, because I've come across so many medical professionals that they just don't get it. And even 8 years into recovery, and they still look at you no different. They still stigmatize. They still don't want to treat you. They don't want to hear what you have to say. It's very frustrating.
Chaps my ass, I'm going to be honest with you. I hate it. Oh,
God, it's annoying.
I can change. I can't change the whole entire world, but I can change those that I come in contact with. And I'll be damned if there's a day where I don't stop trying to change how people view people with substance use disorder or people who use drugs, period.
I think we need to figure out how to change the language in general at the educational level. Because one, there needs to be more education about addiction and everything in general, or substance use disorder, sorry. But since it is kind of turning into a thing, if we approach that without using the words addiction all the time and did use substance use disorder, I think that would just mentally train everyone whenever they get out there. That's how they learn. So that's the language they're going to use. So I don't know how to make that a thing, but man, that would probably be awesome.
That would be so cool. And that's why I'm glad I'm working on this little project for the nurses, right? Because hopefully then the nurses will catch on faster than what they have been, and start talking this way with their patients, with the patient's family. And hopefully it just kind of catches on. I don't know, you can only do so much, but I'll be damned if I don't stop trying.
I think the family thing is big too because a lot of people get on TikTok too and talk about like, oh, my daughter, son, husband, whoever is a addict, and it's they are already kind of talking about it in a negative light just because they're dealing with something and they're probably upset about something. So whenever they come on and constantly use that word, I guess that is one very good example of where suffering from substance use disorder, that would be very, very effective in that stance, but it doesn't happen because a lot of the family members also don't know.
Right. And that's why I'm glad that my family members, not like my family, but my patients' family members will come to them with appointments because boom, we get to wipe it out right there. We get to wipe it out right there. It stops there. It stops there. This is your son, this is your daughter, this is your husband. Stop, stop. And we're able to get a grasp. But that's just like 0.00001% on
Do you
average.
have a lot of, say somebody comes in with their significant other or their child, do you have them being like, I don't want them getting on Suboxone. I don't want it. That's just substituting one thing for another. How do you handle that?
Come at me with that, please, because I'll knock it down in the best way that I can with as much love as I can. And then they see that I love my patients and that they need to be loving on them just as much. Does it work every time? No, I'm not a miracle worker, but we have the ability to change lives. We have that ability. So try me, come at me. Let's do this. Let's sit down and talk.
So do you ever get them to change their, like, do they change their mind, or what happens when someone is just still being like negative about it? How do you handle that? Do you make them leave the room and just talk to the patient?
It's what the patient wants. It's what the patient wants, not what I want. Yeah, get the F out of here if this is how you want to be, but I'm not
Yeah.
the patient. So just because they might not agree with their choice of treatment doesn't mean they don't support them in other ways. And so, yeah, you can stay in the room. Obviously, if your better half or whoever wants you here, please stay in the room. It's fine. I got to let that go. All I can do is educate the best that I can. That's
Yeah.
it. It's up to the patient, really.
I think in general the topic is turning into a little bit more acceptable at least. So I think there is progress being made in the community. If I don't think there's progress being made overall, but at least in the community. Just the stuff that the government deals with that screws up everything by themselves. But we'll talk about that a different day.
Yeah.
Yeah, if there is nothing else, I think we are good to call it. Again, like, you are seriously a lifesaver. Thank you for coming on here because
Yes.
we 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 had contingencies if anyone ever canceled. We had plans for what we were gonna do, but we didn't expect it to be so sudden. So like it's awesome that you were able to come on.
It's okay. I am so happy to support you guys. Absolutely so happy to support you guys. I think what you guys are doing is absolutely phenomenal.
That I think that's all I've got. Thank you
Thank you.
for the description, Jen.
Thank you.
I
But
love you guys.
love you. Thank
We
you so
love you. Thank you. Everyone, thank you for joining today.